Speaker is not working properly. Test mic. Hello, hello, hello. Okay, test. Speaker's fine. Okay. Anna, can you hear me?
Yeah, I can.
Good. Okay, then I can hear you, so we should be good. All right. All righty. Okay, good evening, everyone. First day announcement. There is just no way under heaven we're going to finish everything. And when I have my end of the year meeting with Al and Mindy, I'm going to say what I say every year. This course needs to be a dual course. It needs to have online stuff, just podcasted, and stuff in lecture. There's just not enough time to finish everything in here. It's impossible. It can't be done unless you just say, okay, here are the drugs, bye. And then that's essentially what you get. I'm sorry to say, but that's what you get at Baker. All right. I'm going to give you more than what you get at a place like Baker. And I want to help you not just pass the NCLEX, I want you to ace it. So I've got some, okay, let's stop this and then I'll show everybody. So I have on our Blackboard site, okay, over here. So under course basics, no. Sorry. Course materials, there's this podcasts. So if you click on that, you go to the bottom, and here are the ones essentially that I'm going to need you to listen to. So it's most of this is neuro stuff, and then the migraine headaches, then muscle relaxants, anesthetics, what have you. So 1, 2, 3, 4, 5, 6, 7 of those. And then I'll try to get through, Lord willing, the rest of them. I think the syllabus just needs to be modified, and this course just needs to be a dual administrated course. That's just all there is to it. There's just not enough time to cover all the drugs there are. 20 years ago, there probably was enough time. Not anymore. They just keep proliferating, and I keep having to read the medical letter and stuff like that to keep up with them. And heck, some of the stuff in here is out of date. So that's just the way it goes. So work with me and we'll get through this, okay? And please keep in mind, you can come ask me questions anytime. Some of you have said that during my office hours, the nursing students, second years, have a class. My 1:30, 2:30 office hours. Okay. What would be a better time to come and powwow about pharmaceuticals? Okay. Does Tuesday nights work for anybody? Even at the night?
Yeah, we go 2 to 10.
How about Thursday night? Oh, bag that.
We're loaded up.
Well, then find a time and come ask me. That seriously, I don't think I'm going to find a time that pleases everyone. So find a time, and that's what we'll do. All right. We're thin on the ground tonight, but that's okay. We'll just go. Anyone talk to Audrey recently? How's she doing? Well, of course, her dad died. She's sad. Okay. If anyone does talk to her, give her my love and support, and we're all thinking about her. So, okay. All right. Oh, one more thing. Did you see the video from President Ellis? A former student of SAU, who's a surgeon, is giving the university $1 million for scholarships for nursing students.
Are you serious? It doesn't apply to us though, I believe though.
Oh, are you kidding?
But still,
It's for.
nursing students are going to get money to come study nursing here. You must admit that is good news. That's very good news. One other thing, when I first came here in 1999, there was a sophomore student, her name was Laura Foudy. She was from Indiana. She was an excellent student. She graduated, went to medical school in Indiana, graduated in family care. Then she went to the mission field for about 8 years. Came back and started practicing in Southern Indiana. It was pretty much reserved that she was going to be a spinster, and she was okay with that. Then she met a chap who investigated fires named Luigi, and he was very offbeat and had tattoos all over the place, and he loved her dearly, and they got married. And last year they had their first baby. And I heard on Facebook he had pain in his head, started slurring his speech. The EMTs came, his heart stopped in the ambulance. After an hour of CPR, he was gone. So Laura, I wept when I read that. So Laura Foudy is her name. Foudy, it rhymes with howdy. So to help you remember it. So keep her in mind too, because she's now got a kid. She's got raised without a father. Something she wasn't banking on even in her life. And yeah, so that's great. Father, thank you that it actually warmed up today. And we want to continue to lift Audrey to you. We thank you for her, and also, Lord, for Dr. Laura Foudy and her profound sadness, the joy she had when her little Gracie came into the world, and she has to raise her on her own. And please watch over them. Now, Lord, please watch over us as we cover this kind of touchy topic. In Jesus' name, amen. So if you remember the physiology of your sex hormones, you're pretty much going to know the side effects of them and what things to watch for. So your job as a nurse is to watch for all these things that these hormones do. And when people are treated with these hormones, if you just think back to what they do in the body, that essentially will be a prompt for what things I need to watch for. So testosterone, for example, the larynx grows, and so the voice gets deeper, and you get hair in places you never thought would grow, and you get the production of sperm cells, and you get increased bone density, and you get increased red blood cell production, and increased musculature, and all that. So think virilization when it comes to testosterone. When it comes to estrogen is going to cause the growth of cells in the endometrium. Remember the endometrium? So the uterus has the epimetrium, which is largely just connective tissue, the mesometrium, which is, or myometrium as it's sometimes called, which is big, thick, beautiful, smooth muscle. And then the endometrium has those two layers, the stratum basale and the stratum functionale. And the stratum functionale responds to the hormones. And the shiny basale essentially is the basement layer that attaches it to the attachment attaches it to the smooth muscle, and estrogen causes it to grow. So it's a mitogen. 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 Mitogen means it induces mitosis. It's a mitogen for endometrial tissue. Where else is it a mitogen in the female body? They're found right about here. Breast tissue. Breast tissue. So we see this over and over again in the female body. Estrogen makes more cells. Progesterone induces differentiation. So with estrogen, you're going to need to look for things like ovarian dysfunction because of fibroids or other things like that that are caused by growth and what have you. And also for abnormalities of the breast. People who take estrogen, they really need to do self-examinations. You need to know how to do a self-examination, show them how to do a self-examination again. There was research that showed, 45% of women who did self-examinations, even if they did them, didn't do them right. So show them how to do them and what have you, know what sort of things they should worry about, what things they really don't need to worry about. If you find a little pimple or something like that, don't go running off to the emergency room. What sort of things should they worry about? And there are models that you can get for breast self-examination. You guys seen those? The models, breast self-examination models. One is normal, the other will have a nodule in it, so you know what to feel for. You seen those?
You haven't even been taught
Yeah,
how to
that's
do a
like
breast
an
examination.
You will. There are these models you can maybe you should look into buying those. They've got one. They've got it's got a breast that's got a fibrotic nodule. It feels very different than one that's cancerous. They have a different shape. They have a different feel. So make sure this is something you know how to do. The other thing estrogen's going to do is it increases the risk of blood clots. So DVTs, where do DVTs normally show up? Lower extremities in the calf. So always with DVTs, your leg's going to be swollen and red and warm and painful to the touch. Well, is it red? What do? You compare it with the other leg. And if they have DVTs in both legs, okay, they're really screwed. But that's really rare. So if you have a question, just look at the other leg. That essentially will be your guide. So progesterone is very much the let's get it to differentiate sort of thing. But the other thing estrogen does is estrogen is a very powerful regulator of gonadotropin production by the pituitary and gonadotropin releasing hormone by the hypothalamus. So because of that, progesterone is extensively used as a birth control agent. And the issue with progesterone is abnormal bleeding and irregular periods and spotting and stuff like that. So these are all the things, if you keep those in mind, once we start reciting the litany of things you need to watch, you need to ask about, if you just go back to what the function of these are, you'll say, oh yeah, I remember that from A&P. That's what it does normally. So try to hook or couple your knowledge of physiology with the activity of these agents when they're given as a pharmaceutical. All right, questions? So the first one, and I don't know why the book starts with this one, because it's a bit off the beaten path, but erectile dysfunction medicines can result. So erectile dysfunction can result from just good old-fashioned wear and tear. And it is pretty common with age, but things like high blood pressure and high cholesterol and diabetes, they can contribute to it as well. But it's also a side effect of certain types of medicines. In particular, blood pressure medicines, beta blockers are definitely the biggest offender, and other sorts of things. And it says they're caused by decreased testosterone. That's the other reason why, as you get older, it tends to be more of a problem as you get older. If there is a low testosterone problem, there are treatments for that, and that's fairly easily treated. Now, the drugs that are used, these are also used to treat pulmonary arterial hypertension. So these aren't just so-called whoopee pills. These also have other uses besides being used in older men. And these are drugs that inhibit the breakdown of cyclic GMP inside cells, smooth muscle cells rather. So cyclic GMP, you'll remember, promotes smooth muscle relaxation. Phosphodiesterase 5 degrades cyclic GMP. These drugs inhibit cyclophosphodiesterase 5. Therefore, GMP lasts longer, vasodilation lasts longer, and the erection lasts longer. Now, on the average, these drugs are very well tolerated. Usually when you first take them, dizziness is kind of common. So warn a patient about that. Secondly, if they're on other heart medicines that cause vasodilation, these drugs can combine with the phosphodiesterase inhibitors and lower the blood pressure to dangerously low levels. So really, you probably shouldn't give them, you definitely shouldn't give them to people who are on cardiac nitrates. Natalie, can you name me a cardiac nitrate? Sure you can. It's found in dynamite. Yeah, I like the explosive type. Sorry? Nitroglycerin, yeah, nitroglycerin. That's cardiac nitrate. That's cardiac nitrate. So should not be mixed with cardiac nitrates. No, don't go there. Secondly, there is this condition called priapism. Priapism. That means you have an erection that lasts way too long, and you have your vasculature is at risk of damage, permanent damage. So the tasteless commercials you see on ESPN say 4 hours, and that really is the mark. Now, once you first use these, usually you will have, I guess, according to the insert, you'll have an erection that lasts longer than usual. If it's over 4 hours, there's a problem, and you should seek medical help. The same types of phosphodiesterases are found in the photoreceptors of the eye. So you can get changes in color vision. That goes away. People get really freaked out about that, but just warn them, that's a possibility. You may see a problem perceiving colors.
So they have a problem seeing colors when they take one of these drugs, or?
Yeah.
Okay.
Yeah. Now, sildenafil has a short half-life. It's less of a problem with sildenafil. Tadalafil has a long half-life. That's why it's pretty childishly called the weekend pill. I hate terms like that, but that's what it's called. This has a long half-life. There's more of a risk with that drug. Vardenafil is kind of in between in terms of half-lives. So it's in between in terms of risk. Now, patients can also experience hearing loss. This is due probably, it seems, to vasodilation of vessels near the ear, and that vasodilation impinges upon delicate nerves issuing, auditory nerves, and those nerves can get damaged. So if there is loss of hearing, the drug should be discontinued ASAP. And you can give very quick hearing tests to people where you scratch a tragus and whisper into one ear. And if there's a question, send them to an audiologist, and they'll give them a proper hearing test. And of course, don't use these with grapefruit juice. Yes, Sydney.
Okay, so say someone takes too many of these, is that like an antidote or something? Like, what do they do with them when they go to the ED?
Yeah, ED for ED. If you have priapism, usually by draining fluid with a needle from the penis, that will, excuse the expression, deflate it. That's usually what's done. That's a procedure that ER doctors know how to do. Some ER nurses know how to do it too. If you work emergency, you may get the chance to observe such a thing, or even do such a thing. That's usually what's done. There's usually no pharmaceutical antidote for it. So no nitrates, no grapefruit juice, and use with caution in people with heart conditions.
Did you say grapefruit?
Yeah, yeah, because it's metabolized by cytochrome P453A4.
Okay, what is this fluid that they're draining? Fluid or?
No, the corpora cavernosa fills with blood.
Okay.
Oh, she's I believe Miller.
Yeah, yeah, right. And if it sounds painful, I'm sure it is.
One of mine does too. She told not to interrupt.
You have a question? I hear somebody talking online. Is there a question? No? Oh, okay. If you have questions, please ask. We're all one happy family here. We're mature adults. But we can still laugh at ourselves. Okay. Let's talk about gonadotropins. So the book jumps around a little bit on these. I'll try to stay a little more on the straight and narrow, but no guarantees. So you will remember that the hypothalamus releases gonadotropin releasing hormone, a small peptide. It goes immediately to because of that portal system, the hypothalamic pituitary portal system. It goes straight to the pituitary. You have gonadotrophic cells in the pituitary that, in response to gonadotropin releasing hormone, will release the gonadotropins, which are follicle stimulating hormone and luteinizing hormone. And those essentially will induce the formation of the sex steroids in the gonads. And these are sometimes inhibited if you want to deal with something like endometriosis. So there are antagonists of gonadotropin releasing hormone that are used to treat endometriosis. There is a relatively new drug, for example. It's a oral medication. It's called elagolix. Elagolix, it goes by the trade name of Oralisa. So this drug is it's oral. It essentially binds to the gonadotropin releasing hormone receptor on the surfaces of the pituitary cells. So the pituitary cells will not respond to the hypothalamus. They don't release gonadotropins. And since it's the release of gonadotropins that causes the pain of endometriosis, this type of medication can actually help with the pain of endometriosis. So very quickly, remember, endometriosis is this condition in some ladies where the tissue, endometrial tissue from the uterus has somehow exited the uterus and is stuck to other organs of the body. So those other organs of the body will go through a bleeding and healing cycle every month with the gonads. Depending on where it sticks, it can even stick to your lungs. So this is a very, very painful condition, and people who have this are miserable, truly miserable. And here's the other part about this, it kind of sucks. What really helps an endometriosis patient is a hysterectomy. But insurance companies won't pay for the hysterectomy unless you try the medicines first, because the medicines are cheaper, but the success rate with the medicines is a lot lower. So you usually have to go through years of trying different medicines, then they'll pay for the hysterectomy, which it kind of irritates me. Seems to me your doctor should make that decision, not the bloody insurance company. I will get off my soapbox.
How do they test for endometriosis?
Imaging. Medical history is usually the initial diagnosis. To find the tissue, you can do imaging. You can see it on ultrasound, and then you can be scoped several different ways. Sometimes it's exploratory. That's pretty definitive, but ultrasound is a really good way to see it usually. Also, if your menstrual cycle is blocked and you don't have symptoms, that's pretty surefire. So, okay. I'll continue with this one when we get back to the other drugs that are used to treat endometriosis as well. Let's talk, it says here we're going to look at oxytocin. So oxytocin, I don't know why it's in here. It's not a gonadotropin. But oxytocin is released by the posterior lobe of the pituitary, whereas gonadotropins are released by the anterior lobe of the pituitary. And oxytocin falls in this group of so-called uterine motility drugs. Uterine motility drugs. It's a very small peptide. It's 9 amino acids long. So it's made synthetically. And this is the product that gets called Pitocin. This is the one that is used to induce labor. So oxytocin is used to induce labor. It's also used to prevent postpartum hemorrhage after labor. So it's used for both of those. It's either given intravenously or it's given intramuscularly. If it's given intravenously, works right away. If it's given intramuscularly, it'll take 3 to 5 minutes to start working. So either way, it works pretty fast. Intravenous has a duration of action of about an hour. IM, usually about 2 to 3 hours. Usually if you're being induced, you get bumped up because that's what your body does. Because the production of oxytocin undergoes a positive feedback loop. So to simulate that, the nurse will put you on the low dose, and then as your contractions start to get more powerful, he or she will increase the drip rate and increase the dose until you're in full-blown labor. All right, so they're also used for the letdown effect in nursing, and that you guys know that already. I don't want to belabor that. Okay, now some people can have allergies to Pitocin. They're not very common, but they have been reported. So give a test dose first before you actually use the whole thing. Common side effects are upset stomach, nausea, and dizziness. That's usually overcome by the fact that she's having a baby. So, which kind of trumps headache and GI discomfort and so on and so forth. Now, the contractions can raise blood pressure. So you want to be cautious about people with coronary disease or hypertension. Also, if you have a woman whose baby is not in the proper position for birth, giving oxytocin can be quite disadvantageous to her. So you have to have proper fetal position. And also the woman's pelvis has to be anatomically normal. If you have an anatomically abnormal pelvis, and her OB should know, then essentially oxytocin can actually be quite detrimental. Okay. If a woman has had a previous C-section, she is at higher risk for uterine rupture. Now, can women who've had a C-section have a VBAC, a vaginal birth after delivery? Absolutely. Happens all the time. And I get a little peeved at women who judgmentally shake their fingers at hospitals and say, they do too many C-sections there. And the reason OBs have gotten kind of overly cautious is due to the fact that women who've had C-sections are at higher risk. Because they're at higher risk, the hospital doesn't want to get sued, so they have an overly conservative policy. That policy isn't just about being sued, it's also about maternal safety. So before you shake your finger and talk about a bunch of money grubbing, insert swear word modifier, whatever, doctors, the fact is that policy also exists to save mothers' lives. So I don't have any good answers on that. When, what policy to use and blah, blah, blah. That's up to the hospital administrators to work it out with their doctors, their staff, and their algorithms and things like that. All right. Oxytocin can sometimes cause decreased fetal heart rate. So monitor the fetal heart rate. And sometimes the uterus can actually spasm. Instead of properly contracting, it just kind of spasms. If you use oxytocin for too long a period, you can actually cause water intoxication. Water intoxication. That's led to maternal death. So don't use it for too long. All right, so the R in the word nurse, what's the responsibilities of the nurse? So first thing, when the mom-to-be gets there, you do a complete examination, establish a baseline before you do anything. That's kind of a dub, but it's worth mentioning. Look for the things that are cautions or contraindications. Look for drug allergies. Look for current status of lactation. Look for uterine atony, lack of tone in the uterus. Hypertension, any potential complications. Monitor lab results, coagulation studies, complete blood count, so on and so forth, to evaluate the hematological status. The patient will have acute pain, comes with having a baby. There are medications for that. This other drug here, methyl ergonovine, that drug has a lot of side effects. It's not used very much. And I looked essentially for companies essentially that sell it. Not very many companies sell it. I think the last time I heard this drug being used, it was used by midwives who do home births and are into these natural birthing things, and they give herbs to make your uterus go. And these herbs contain this stuff, methyl ergonovine. Oxytocin is orders of magnitude safer than that drug. So here are the side effects of that drug. You ready? Nausea, high blood pressure and blood pressure swings, weak pulse, dyspnea, chest pain, numbness and coldness in extremities, confusion, excitement, delirium, convulsions, coma, death. That doesn't sound good. Yeah, just use Pitocin, okay? Just use Pitocin. Dinoprostone, that other drug there, that drug is usually used for so-called vaginal ripening. Vaginal ripening. Sorry, cervical ripening. Let me get it right. Cervical ripening. Comes as a gel or a suppository you put in. And it's meant essentially to get the cervix to start to ripen, to start to dilate. If you have someone who's just not dilating, you can put that in as a suppository and it will actually work. Carboprost is usually used for abortions. That's used usually after the abortion to remove the products of conception. Good gosh, I hate that term. Little commercial. I'm staunchly pro-life. Staunchly. My job is to train you as nurses. We will talk about abortifacients. We have to. It would be dereliction of my duty to not talk about it. Having said that, I oppose abortion in every form, with every fiber of my being. There, I got that out. That's what carboprost is usually used for. I can't do it. The last time I read about it being used in maternity wards was 20 years ago. The paper was 20 years old. Yeah. 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 So if the placentas, if the part of the placenta's left in and it just won't come out, which nowadays doesn't happen very often, with the Pitocin quality is very high grade. It's usually very effective. The injection into the umbilical vein, number one, usually expels the placenta really well. 2, it helps the mom's milk come in. 3, it helps her pelvis actually come back to normal. And most moms will say when they start giving their kid the first lunch, they can actually feel their pelvis actually starting to contract. Some will even say it kind of hurts. Okay. So make sure you monitor bleeding after giving birth. Make sure you regulate the oxytocin delivery. And it's really important you ensure that fetal position is as it should be, head down. If the baby's breech, there's a maneuver, a massage maneuver you can do. It's been used by midwives for centuries to turn the baby. I'm blanking on what it's called. Yeah, you move the baby just a little bit, then just a little bit, then just a little bit, then just a little bit. And then sometimes you do that, the kid all of a sudden just goes, and just kind of puts their head down and they're ready to go. That doesn't work all the time. And some women just have a uterus that's just too small for you to maneuver, and you have to do a C-section. That's just all there is to it. So those are things. So the fetal position, make sure that's something that you ascertain as well. Okay. Questions about oxytocin? Okay. We will soldier on. We talked about vaginal infections already. So now we're at endometriosis. So danazol is an androgen. So it's used for endometriosis. It's also used for fibrocystic breast disease. So this is going to inhibit the release of gonadotropins. This comes in lots of different forms. There's an IM injectable, but there's 3 different forms of IN injectables. One of them peaks at 1 to 3 days. Another one, 2 others peak at 2 to 4 weeks. So that the kinetics essentially of release are different. There's a buccal form. So it comes in a strip. You just put a little pinch between your cheek and gum, and that's how you get the drug. Then there's a dermal form, and the dermal form has a rather rapid onset. Allergies to androgens are well documented, so make sure your patient doesn't have an allergy to it. If your patient is pregnant, this drug will have deleterious effects on the baby. It will also have deleterious effects on lactation. Not completely clear if androgens enter breast milk. Estrogen and progesterone do. Androgens, maybe if they do, a little bit does. It's not really clear how damaging that is to the baby, but it will, excuse the expression, dry up your mom. So be careful of that. If you have cardiovascular disease or liver disease, this drug will make it worse. If you use the dermal patch, there's a black box warning. in the insert of this drug that it will virilize children who come into contact with it, or kids who touch the clothes or the skin of people who use this drug. So you should make very sure that kids don't get in contact with this drug. So the patch should always be folded in half and summarily flushed down the commode. It increases the risk also of venous thromboembolic events, VTEs, venous thromboembolisms. Increases the risk of intracranial hypertension. And it can cause hepatitis as well. So it will cause anti-estrogen effects in women. So it'll cause a lot of the signs of menopause, flushing, sweating, vaginitis, nervousness, emotional lability, shall we say. Because of fluid and electrolyte changes, headaches are pretty common. Dizziness, sleep disorders, fatigue, rash. There's also a documented increased risk of hepatocellular carcinoma. It also has androgenic effects on women, so it'll deepen the voice. It'll cause oily skin and hair. You get weight gain. Your breast size will decrease. Your breast will shrink. You'll start to grow facial hair. You'll get swelling and acne. Yep, that's where it starts to grow, but it grows down here. Grows here too, actually. Okay. Androgens can decrease thyroid function. So if you're testing the patient for thyroid function and their thyroid function is low, keep in mind the androgens may be responsible for that. Secondly, you get increased clearance of creatinine if you do a creatinine clearance test for kidney function. That is a function of the androgen. And these effects will last about 2 weeks after the drug has been discontinued. So your mission, should you choose to accept it, is to essentially, assess for the cautions and precautions that we talked about, perform a thorough physical exam, get a baseline, if the drug is being used on children, because androgens can close the epiphyseal plate, get an X-ray of the long bones, so you know how long the long bones are. Also, androgens may cause a disturbed body image. So ask questions about how they feel about themselves, mood changes, things like that. Monitor liver function, very important. Monitor response to therapy, of course. And since electrolytes are an issue, make sure you monitor electrolytes as well. And what have you. So that's danazol. Danazol. Now, Ferolin is a drug with a completely different modus operandus. So this drug is a agonist of the gonadotropin releasing hormone receptor. But what it does, it binds a receptor so tightly that the receptor gets really activated and then simply fails to react to it anymore. So it burns the receptor out. Burns the receptor out, so to speak. It's also used to treat uterine fibroids. It gets used a lot in the control of ovarian stimulation during in vitro fertilization protocols. This is administered as a nasal spray. Nasal spray, of all things. Lupron works in about the same way. So the biggies with these drugs essentially are the anti-estrogen effects that we mentioned before. The hot flashes, the sweating, the vaginal dryness, all that stuff. It's also used in young boys and girls to treat precocious puberty. So that's Lupron and Nefarlin for endometriosis. And then this other drug that we talked about, this is an actual receptor antagonist. This drug, unfortunately, can cause decreases in bone density. You also get the usual hot night sweats, hot flashes, headache, nausea, insomnia, mood swings, depression. Those are all anti-estrogen effects. Also reported in clinical trials with this drug, it happens rarely, but suicidal ideation was reported and swings in moods. This drug is a cytochrome P450 3A4 substrate. So if you use it with 3A4 inducers or inhibitors, you'll have a problem because you'll increase the half-life of it or greatly decrease it and work. Very good. Okay, questions? We talked about STDs already. Okay, I'm gonna whip through. You know what? Good golly, how'd it get so late so fast? Time flies and having fun, I guess. Let's take our break. So let's come back in 8:03, I guess. 8:03, and then we'll resume. Yeah.
What did you think about the couple students that asked you about a case study instead of a final?
I don't like that idea. I don't like that idea.
Are we still, because there are two more that you haven't set a due date for, are those gonna? Do you want those? Because there's two more.
Yeah, I know. Okay, calendar. Mercy. So the case study 3 is the hypertension one. Case study 4 is the asthma one. Yes?
I have not.
Yeah. So case study 3 is the hypertension one. Case study 4 is asthma. Let's have case study 3 be due on the 3rd of May. And the case study 4 is extra credit. How's that sound?
Is that additional to the two like science centers?
Oh, sure. Why not? I'm vaccinated. I'm feeling generous today.
Hey, what about if we got our shot? Is that a little extra credit?
No, come on. You have to get shots to be in the program.
No, not our COVID. Not our COVID.
But you're bloody crazy if you go to wards without being vaccinated.
Huh? Just like hospitals. And our flu shot.
You need a flu shot to be in the program. I know I look really stupid, but I'm not that
I've never
stupid.
seen your eyes roll so far back.
Hang with me a while, you will. So,
I also have another question. Sorry.
I have to honestly say, after finals, I'm going to miss you guys sorely. I really am.
You're not teaching any classes for third year?
It's all clinicals. It's all the clinical staff.
Oh.
I'm the basic science staff, and it's so close to you guys, and then I say goodbye, and it's so sad.
There's no party. I'm
Ooh, party. Let's have a party instead of a final. Yeah.
Girl, who raised you?
I thought we were gonna have a shindig.
Yeah,
Oh, man, we were gonna have a shindig.
I missed it.
yeah,
I'm just kidding.
yeah.
We can have the final and the shindig at your house.
Well, no, I'll have the final here, and then we'll
Oh,
have the shindig over at my place.
Final.
just the final keep shindig.
So in the past, we did a kind of a BYO thing. We provide what do we do? We did chicken wings or something like that and stuff, and then you guys bring whatever else you want to bring, snacky foods or dessert or whatever. So, sorry?
So are you writing the final?
Yeah.
Or is it already written?
Oh, good. Oh, it's not already written.
I think it's a final in Matt. That's like, I didn't know if that was the one. Because people know what I'm talking about. I know what you're talking about. No, there's one on like the Connect thing, so I didn't know if it was that one.
No, the one on the Connect. No, the one on Connect is practice. Yeah, we're having a shindig. We're so having a shindig. So it's the test is the 12th of finals week. So we could do it.
Wait, what?
Wait, what? Who raised you?
Who raised you?
It's the 12th.
Okay, sounds great.
Because it's a night class. Night classes have their finals at the time of the night class.
And it wouldn't change. And it would change. So the dosage calculations, when are those due?
What?
The dosage.
Dosage calculations are due the last Friday, 7th.
The 7th? Wait.
All right, 7 minutes.
So all four of them?
All 4 of them, but you can turn them in gradually if you want.
Wait, what are we turning in directly?
The
Yeah.
calculations are due on the 7th.
Yeah.
They're due on the 7th?
Yes.
It says the 14th on the syllabus.
Well, he has the right to change it.
Well, I know that.
He reserves the right to change it. Girl. Shin, wait, what is it? Shin, like shin, like the anatomical shin.
And then day.
That's your video. Actually. And then day.
Okay, time to resume. Okay, folks, one thing about your case studies. The biggest mistake, you guys nailed the diagnosis, drugs, you got the drugs right. That very, very well done. The biggest problem was when I asked you what questions would you ask her? Remember, OCD is ego dystonic. That means the patient has these invasive thoughts and they're ashamed of them. So these rituals, these compulsions that are meant to deal with the obsessions, they're ashamed of those. They often do them, they hide them. They do them in secret. You come out and you ask them about them straight away, they'll deny them. They'll deny them. So you need to back into it. Yeah, yeah. So I'm trying to get you thinking about, because very often the nurse does the initial interview. So instead of saying, well, why do you clean so much? You've had a discussion, you had a medical history. So just ask her, for example, well, how much do you check each day? Really? How much time does that take? So do you think that's a lot? See, you get her to admit it. By getting her to admit it, and then you kind of go to the next thing. So then what else? This thing, well, how much time does that take during the day? So you do it 1 or 2 times, really more than that. Well, you tell me how many times you do that per day. Oh, really? Okay. You back into it. You let them essentially say, yeah, I do this. And then they essentially come to the realization themselves, yeah, I've got a problem. If you confront them head on, they'll scurry like the little white rabbit in Alice in Wonderland and go straight down the rabbit hole. Right. By just very gently. And it's not easy. This sort of thing takes practice. Some people are just naturally very good at it. You've got to be patient. You really have to be patient. And many of you noted too that SSRIs, they don't work right away. They take up to 4 weeks to start working. And many people will take them for a week or two, say it's not working, and stop taking it. You have to tell them to keep taking the medicine, because the medicine, the activity of the medicine depends upon changes in gene expression in the neurons, actually, the serotonergic neurons. So, okay, enough about that. Otherwise, job well done. Pat yourself on the back. Okay, that's enough. And we'll move on. Prostate diseases. Now, we talked about prostatitis. When guys get older, the hormone dihydrotestosterone causes the prostate to enlarge. This is a hyperplasia, more cells. And this is called benign prostatic hyperplasia. This is determined by the so-called digital exam. And the digital exam is also coupled with PSA tests that are blood tests. And PSA tests need to be coupled with a digital exam, because not all prostate tumors overexpress PSA. 20% of them don't. So you must couple PSA tests with a digital exam. A digital exam will tell you if the prostate is enlarged. But if the PSA goes above a certain level, then that tells you there's probably a mass in there that's overmaking it. And the digital exam will usually, you can feel a hard spot on the prostate. So the enlarged prostate can take the urethra, the prostatic urethra, and compress it. That can make emptying the bladder very difficult. It can also cause urinary frequency and incomplete emptying of the bladder. That can lead to bladder infections. So how do you open that up? You use alpha-1 antagonists. So alpha-1 antagonists, we said were not very good for blood pressure, but they are good for BPH. Now they relieve symptoms. They don't shrink the bladder, but they do relieve symptoms because the smooth muscle of the prostatic urethra is loaded with alpha-1 receptors. And these are blockers of that, and it causes those smooth muscles to relax. So if, hang on, if they end in zosin or losin, they are alpha-1 blockers. Yeah.
What point, so like actually females get pelvic exams past years. At what point do they start like doing digital exams for men?
Age 40. Age 40, yeah. It's not pleasant, but bend over and take it like a man. Okay, so these other drugs that end in "ide", those are inhibitors of the aromatase enzyme that causes testosterone to be converted into 5-dihydrotestosterone. So these are 5-alpha reductase inhibitors. 5-alpha reductase inhibitors. These will actually shrink the prostate, but they do so slowly. Whereas these will tend to work right away. These only work slowly. Very often these drugs are coupled together and they're given in a combination medication. Now, the big complication of these drugs usually is hypotension and dizziness, sleepiness, faintness, and so on and so forth. That usually wears off. But it gets worse if you're older. And if you're older, that hypotension and sleepiness, what have you, is more pronounced. Also, if they're already taking antihypertensives, these will add to the antihypertensive effects, and the blood pressure may really start to drop, maybe even dangerously. There may also be failure to ejaculate because the constriction of the prostate during ejaculation also depends on alpha receptors. Now, some are worse about this than others. So tamsulosin is one of the big offenders in that regard. And then there's also an issue following cataract surgery where the iris can't properly contract. That's called floppy iris syndrome. Floppy iris syndrome. And since this drug is used, these drugs are used in people who are elderly, since elderly patients tend to get cataracts, they're the ones who usually get cataract surgery. So you hold the drug before cataract surgery. And if they're going to have cataract surgery, you need to warn them about that. So alfuzosin is contraindicated in dudes with liver disease. Doxazosin also should be used with caution in people with liver issues. liver impairment. There's a drug that's not up there, it's called silodosin. That's used as well. That's completely contraindicated if you have liver failure or renal failure for that matter. And if you combine these drugs with PDE5 inhibitors like Viagra, like sildenafil, tadalafil, vardenafil, your blood pressure can drop dangerously low. Fluticin and then silodosin, they are metabolized by cytochrome P453A4. So if you use macrolide antibiotics, those macrolides will tend to increase the levels of these drugs in your system, with the exception of azithromycin. So monitor blood pressure. Your job. Have your patient monitor blood pressure too. Make sure they take the medicine same time each day. Usually helps to take it with a meal. Camulocin you're supposed to take after a meal. 30 minutes, yeah, 30 minutes after a meal. And those are the drugs essentially for prostate, enlarged prostates. Prostate cancer is a whole nother ball of wax. And here it throws in the HPV vaccine. Let me just say a quick word about the HPV vaccine. Papillomavirus does not induce much of an immune response at all. The HPV vaccine induces a beautiful, gorgeous, robust, protective immune response. So this vaccine is extremely effective. Now, there is a campaign online that says that Gardasil kills people. Again, if you check the VAERS website, the vaccine adverse events reaction site, and compare the HPV vaccine with other vaccines, guess what? Rate of death isn't any different from the other vaccines. It's very safe, and extremely effective. Now there's all kinds of debate. Okay, well, if my kid's not sexually active, should she get the vaccine? I think it's up to each parent. That's up to parents. So it's a good vaccine, though. Don't let people tell you it kills people. No, it doesn't. Cervical cancer kills people, not HPV vaccines. All righty. Oh, terrible. All right, so drugs for infertility essentially include drugs to help you ovulate. And most of these are either follicle stimulating hormone analogs. Your book doesn't list very many of them, but there are quite a few of these. So clomiphene stimulates ovulation. Clomiphene is a luteinizing hormone mimic. this right. So this drug, cetrorelix, this is a gonadotropin releasing hormone mimic. So this will cause your body to release luteinizing hormone, and then those will go on to induce estrogen. This is given by injection. Then you have drugs that are follicle stimulating hormone mimics. Many of these are just genetically engineered versions of this that are overproduced and then packaged and sold. There's folitropin. There's a folitropin alpha, there's a folitropin beta. Folitropin alpha is called gonal. Gonal F, the folitropin beta is called folistim. Folistim. And these, you inject them and they, there's another one called ganirelix. That's a follicle stimulating hormone activating. It's a follicle stimulating hormone mimic. So these essentially cause your ovaries to mature several oocytes at once. And then you give clomiphene essentially to induce ovulation. And then these tend to be harvested by procedures where you go through the abdomen and then you essentially pop the ovum and then you take the egg out and then you put the egg in culture and you fertilize it and what have you. Menotropins are mixtures of gonadotropins that are given to guys to increase sperm production. To increase sperm production. That's what menotropins are. Human chorionic gonadotropin is also given to mature ovaries. These particular drugs, because the ovaries get so stimulated, there's a risk that you can divert fluid to the ovaries away from other tissues. That's called ovarian hyperstimulation syndrome. It's much more common in younger women. Younger women say you want to be egg donors. Not so very common in older women. Also the protocols. Oh, there's
Sorry,
a,
I used to like distract you. I'm
oh,
sorry.
okay. Like what? You're talking about in vitro fertilization. Oh, pish posh. Oh, okay. Oh, yeah. But in younger women, that's a genuine concern. This sort of ovarian hyperstimulation syndrome, because it diverts all this fluid into the abdomen, it can cause other organs to shut down. So that's your biggest concern. It's not nearly as likely in older women, but it can happen. And if it happens, it can be potentially life-threatening because your blood pressure can crash and you can go into shock and then you can die just from organ failure. So you need to make sure you watch essentially the, you can use ultrasound to look at the ovaries to see how many locules essentially have been matured. You need to watch blood pressure and you need to watch electrolytes as well. And the woman is typically pretty uncomfortable, usually, with these. Guys with minotropins, there's pain at the site of injection, and then there's testicular pain. Beyond that, there's really not a lot of side effects in guys. The dosages are not that high. That's probably part of it. All right. Estrogen replacement therapy, hormone replacement therapy is being used less and less because the risks, it turns out, don't really outweigh, the risks tend to outweigh the benefits. If there's a benefit to it, the benefit is only for about the first 5 years. The real benefit for hormone replacement therapy is bone density. Because once the woman stops producing estrogen, bone density now can really start to tank. And if her bone density is poor, when it was at peak, then hormone replacement therapy can be something that could definitely benefit the patient. All right, so with hormone replacement therapy, the big issue, of course, is that you're going to get cell division of the uterus. With estrogens as well, you have an increased risk of blood clots. You have a potential risk for estrogen-dependent breast cancer. And there's a risk for endometrial and ovarian cancers. So those are kind of your triad of things that you're going to watch for. Do not give estrogen to breastfeeding women. It's excreted into the breast milk. Do not give estrogen to pregnant women. It's not safe for the baby. It's contraindicated in someone who has a family history of estrogen-dependent breast cancer. Contraindicated in people with a history of thromboembolic disease. Also contraindicated in people with atypical vaginal bleeding that is undiagnosed. Smoking increases the risk of VTEs if you're using estrogen. Advise, beg, importune your clients not to smoke while they're on estrogen. If you use corticosteroids with the estrogen can potentiate the effects of the corticosteroid. Estrogens can reduce the efficacy of warfarin, if they're going to use warfarin. If you're going to use estrogen, take it at the same time every day. Make sure you show them how to do breast exams and make sure that they report any redness in the legs, shortness of breath, any swelling or chest pain, swelling in the breast, chest pain. If they're going to have hip or knee surgery, discontinue it before. And if they use a patch, it should be applied to the waistline. Don't put it, strange places. Yeah.
So is this used, might be a very weird question, is this used for like people who,
Hormone therapy.
yeah, like for people who changing genders?
Yes,
Yeah.
yes. It's not FDA approved for that, but it's used anyway. We're treating kids as guinea pigs. They're handing that stuff out in the hopes that on handing this stuff out, they can get it approved based on that data. No phase 3 trials, they're just using these people as guinea pigs. I think that's unconscionable. And yes, you may quote me. Oh, by the way, conjugated estrogens, they come from the urine of mares. It's just extracted. That makes it really cheap. There's some people who say, if you're going to use estrogen, you must use bioidentical estrogen. Well, guess what, coaches? This has been tested against the conjugated estrogens. Guess how much difference there is between them when you do a head-to-head test in a clinical study. They're the same. Use the cheap stuff. Okay, we will continue this on Wednesday. I apologize for getting the quiz up so late. My weekend kind of militated against it. So the quiz is due Friday. It's up, it's due Friday, so you have plenty of time to do it.
I think it's due Thursday.
Thursday.
April 29th.
But I made it Friday. Let me check that.
Oh, say it back, Andrea. Say it back. Say it back. I'll see more, Andrea. Oh,
Okay.
she didn't say she doesn't care about me. She said she'll be thinking.
Oh, I
about
know.
me.
I thought it was spring
Thinking
arbiter.
about her. Huh?
I thought it said spring armor nursing at the board to get that. That's so cool.
Okay, now it's due Friday.
Two questions. Well, 3 questions.
So bad.
I emailed you my summary from the 3rd science seminar. I didn't know if you got that or if I should send it again.
I don't.
And then also my last case study, I haven't gotten a grade for it yet. I sent off that